Okay, might as well just keep going. We're on a roll here. So let's talk about the appendicular skeleton, and I think I'll just talk through the whole thing and be kind of quick about it, and then we'll be done. So let's start with the pectoral girdle, which is the clavicle and the scapula. Okay, and those are the two bones of the pectoral girdle, pectoral referring to shoulder region, and it's an incomplete girdle, right? There's nothing holding the scapulae together back here. Compare that to the pelvic girdle, which the ilium attaches to the sacrum and the two pubi come together. So this is a complete girdle down here, and it's, you know, it forms a complete ring, you know, a complete girdle. Whereas the scapula and the clavicle do not form a complete ring. So this allows much more movement, right? Which is a good thing for our arms and shoulders and everything. The clavicle has two ends, one end that goes to the manubrium of the sternum, and one end that goes and attaches to the to this process at the end of the spine of the scapula, which we'll get to. It's called the acromion. Okay, so clavicle means like a key or little key, and the sternal end, well, sternoclavicular joint. So we have a sternoclavicular ligament, which we'll just remove momentarily there, and there you have it, the sternoclavicular joint. And oddly enough, that is the only thing holding your arm to the rest of your skeleton in terms of a connection to bone, right? There's nothing else. It's without that little ligament, pop, this whole thing, you just, now obviously your arm doesn't just fall off, but that's because you have a lot of muscles that span the joints and hold things together, right? So you have muscles that go between the spinous processes of your vertebral column and this medial margin of the scapula. You have muscles that go between the sternum and the ribs and attach to the humerus, for example. So you don't just, you know, your arm doesn't fall off, but that's the only bone-to-bone attachment, is that little sternoclavicular ligament. So this is a sternoclavicular joint, and there is an acromioclavicular joint with an acromioclavicular ligament. Acromio is referring to the acromial process, the acromion right there, which is, you know, you can kind of feel the spine of your scapula, and it ends, you know, this, I don't know, it's the acromion. There's got to be a more common word for the top of your shoulder there, but you can palpate that, and you can palpate the clavicle, and I don't know, you can do glamour shots, right? You got to show off the clavicle in the glamour shots. I don't know why, but it's apparently sexy. So okay, so that's the clavicle and the scapula. The scapula's got quite a few landmarks of interest on it, and I wish we could click around on it, but the spine of the scapula, which ends in the acromial process or acromion, and so going with the spine there, let me kind of fade everything else out here for a minute. There's a supraspinous fossa, this depressed area, and guess what? There's a muscle in here that's going to be called the supraspinatus. There's an infraspinous fossa, and guess what? There's an infraspinous muscle, and there's a subscapular underneath the scapula, subscapular fossa, and there's a subscapularis muscle that's going to be attached there. So that's all very nice. Coracoid process. Remember how we had a coronoid process in the mandible? And now we have a coracoid process, which means the same thing. Look, it's a beak, somebody said. Let's call it a beak. Why do we name all these little processes? Because things attach to them, right? So here's a ligament between the acromion and the coracoid process. So guess what? It's a coracoacromial ligament. And anyhow, this joint, this acromioclavicular ligament and the acromioclavicular joint, and let me get that into better view. The acromioclavicular ligament can get broken. Bam, you get hit, you know, in football practice or in the game, and you get a shoulder separation. It's the AC separation. You damage that acromioclavicular ligament, you might break it all the way off. So maybe you didn't break the clavicle, which is easy to do on its own, but even if you didn't break the clavicle, you can get an AC separation, and then you're out of the game for a bit. All right. The other part of the clavicle I want to mention is the glenoid fossa, which is where the head of the humerus will articulate, right? This is a ball and socket joint. The head of the humerus is the ball. The glenoid fossa is the socket, and it's a shallow socket, quite shallow, meaning not so stable, but high mobility. So let's check out the joint capsule here a little bit. So here we have this articular capsule that we're going to hide, and the inferior glenohumeral ligament, so just helping hold the humerus onto the scapula there. And again, you have muscles that we're not seeing that help with this too. But let's remove that, and you know, we just middle glenohumeral ligament, superior glenohumeral ligament, a coracohumeral ligament, so going from the coracoid process to the humerus, coracohumeral ligament. And what we're left with is what I wanted to point out here, the glenoid labrum. So just this little ring of cartilage. This one's not a ligament, it's just a little ring of cartilage that helps deepen that joint a little bit, helps hold things together. Labrum meaning lip, so a little lip around the glenoid fossa, or glenoid cavity as it's sometimes called. Okay, good enough. Now, landmarks, like I said, landmarks are attachment points oftentimes. So we will see that with the humerus. Let's go head to the humerus. And the head of the humerus is this nice smooth ball. The neck of the humerus is just this small little, tiny little line there, little depression around the head. That's it for the neck of the humerus. So that's the anatomical neck. But if they're actually having to replace this joint, then they'll just cut it off right there. So there's a surgical neck and an anatomical neck. And the head, I should mention, is covered with cartilage because joints between bones, you know, typically have cartilage there. Now we have some bumps and grooves and things, and we will kind of revisit these more with muscles, but you might as well try to learn them now. There's a greater and lesser tubercle. Now, a tubercle is just a bump, so we have a greater tubercle, which is just this rough bump here, and not as easy to see, but there's a lesser tubercle. Greater tubercle and lesser tubercle, and in between them, and this is a lot easier to see on an actual bone, but there's a groove between the two tubercles, right? So this groove is called the intertubercular groove, and if I could sing, which I can't, or play an instrument, which I can't, and if I started a band, which I won't be, but I would call it the intertubercular groove. So that band name is still available. If anybody wants to take it, go for it. Seemed good to me. Okay, another thing that's even less apparent, especially on this, well, kind of, this has got to be it right there. See that little bump? Whoop. That's the deltoid tuberosity. Ooh, wow, cool. It's the attachment point for the deltoid muscle, the insertion point. So this is where the action of the deltoid is applied to. And it's going to be thicker if somebody has a bigger deltoid and if they're, you know, doing a lot of deltoid exercises. And if you want to really be impressed with the deltoid tuberosity, then kill a gopher and boil its skeleton so it's nice and clean. And that's just got a little tiny humerus, but man, does it have an impressive deltoid tuberosity from doing this all day. So a gopher really knows how to exercise its deltoid. All right, so the shaft of the humerus, also called the diaphysis, remember, and then down towards the distal epiphyseal region here, we have some interesting landmarks. We're getting joints, and man, should we have a separate joint lecture? Maybe, but let me remove some articular capsule and the annular ligament. Annular is like a ring, and this is the ulnar collateral ligament because this is the ulna here. Okay. There's the radial collateral ligament. So there's a radial and an ulnar collateral ligament. Collateral ligaments are on the sides. And there's your elbow, right? Elbow, which is the ulna. And of course, there's just a name for the process, the trochlea. Sorry, the trochlea is the notch. I'm running out of steam here, and I didn't review this section, so it'll come to me in a moment here. There's the ulnar collateral ligament. So we have the radius. Here's the head of the radius. Let me talk about radius and ulna. We still need to do, this is the medial epicondyle of the humerus. Okay, so, and you can feel that real nicely. Medial epicondyle, and there's a nerve there. It's going to be the ulnar nerve come running down, but you can hit your funny bone. It's that ulnar nerve that you can tap, and it's unpleasant. Okay, so there's our ulnar collateral ligament, and this then, that's the medial epicondyle. And if you have a medial, then you've got a lateral, right? So there's a lateral epicondyle, but it doesn't look too impressive. Epicondyle, it's around the condyle, which is the articular surface. So you'd say, oh, great, so this is the condyle. Well, no, not exactly, not the condyle, because we're going to take this little piece of articulation and divide it into two sections, just because we have two bones attaching. We have the head of the radius, which is going to articulate with this nice rounded section. And it would have been nice to just call it the lateral condyle, but no, they decided, oh, that we'll call that the capitulum. And this could have been just the medial condyle. Oh, no, let's call it the trochlea, because trochlea means pulley. And look at this, it's like a pulley system going on here with the ulna, right? If we click on the ulna and we fade the others out, there's our trochlear notch on the ulna, right? Let me see if I can get that from this angle. There's the trochlear notch. And now I told you I'd remember that this is the olecranon or olecranon process right there. Nice thick piece of bone, the olecranon process. So there's a trochlea that, like a pulley or semi-lunar notch sort of thing, and we can divide it into two processes. I'm going to skip for now. Well, the olecranon process, and is this another coronoid process? Coronoid, no. I should review. It's been several years since I've taught this. There's an interosseous ligament or interosseous membrane between the radius and ulna. keep that there. But let's go on down. Let me zoom out a little bit. The radius, the head of the radius is proximal, and the head of the ulna is distal. So these bones are kind of flip-flopped from each other. It's like the ulna is standing on its head, right? And if we look at the wrist joint here, the radius expands on the thumb side, radius on the thumb side there, and there's a little process there, and here's a little process here on the lateral side, on the ulnar side. And remember the styloid process of the temporal bone? Well, somebody liked the name, and they wanted to also call this a styloid process. So it's like a little pen, and that's kind of believable. It kind of looks like a pen-like process there on the lateral side, the ulnar side, lateral styloid process. Medially, not as pen-like, but there's a medial and lateral styloid process. And you can see that these are going to articulate with the carpal bones, which I briefly went over in the first video, so I'm not going to talk about carpal bones. But it's worth mentioning that we have lots of ligaments here, palmar ligament and extensor retinaculum, and we have muscle tendons and nerves going through, and we sometimes get carpal tunnel syndrome, and we have to release one of those ligaments. Okay, so then we just have the carpal bones, and then our phalanges. Metacarpals. First metacarpal, second metacarpal, third, fourth, fifth. So 5 metacarpals, and then phalanges. We have proximal, medial, distal phalanx. And in the thumb, or pollex, we just have a proximal and distal phalanx of the pollex. Pollex or thumb, hand or manus. And not surprisingly, we have articular capsules around these joints, little joint capsules, and this is called the distal interphalangeal joint. Distal interphalangeal, DIP. So that's a dip, and this is a PIP, a proximal interphalangeal joint, right? Because it's between two phalanges. So there are pips and dips, proximal interphalangeal joints, distal interphalangeal joints. And this is between phalanx and metacarpal, right? These are your knuckle joints, or your knuckles. And so this is metacarpal phalangeal joint. These are metacarpal phalangeal joint capsules, or articular capsules. All right, we have a similar story for our legs and our pelvic girdle. I could either stop here and make a separate video, or let's just keep going and do all. You can pause and come back later if you want, or speed through it at double speed. Okay, so our pelvic girdle is made of an ilium, an ischium, and a pubis, right? So let me show everything again. There we go. So ilium, ischium, pubis, along with the sacrum, form the pelvic girdle. So the sacrum, of course, is axial skeleton, but that's okay. We still like it. And these three bones come together. Let me. I don't know if I can. Let's see if can I hide the whole upper limb. Bam! I'm getting better at this game. So I'm also going to try to hide the lower limb for now. Wow, look at that. And so all three bones do come together. The ilium, the ischium, and the pubis come together to form this deep socket, right? We had a shallow socket up at the shoulder. Here we have a deep ball and socket joint. And this space where they come together, this deep socket, is called the acetabulum. And if you remember, acetic acid is vinegar. Acetabulum is a vinegar cup that the Romans apparently would dip bread into a vinegar cup. I don't know, I've never seen a vinegar cup, an acetabulum, but that's what that was named for. And just like we had a glenoid labrum to deepen the socket a little bit in the shoulder, here we have an acetabular labrum, which I'll just hide. And we have articular cartilage here. This is covered with cartilage, just like the head of the femur will be covered with cartilage. And let's see, for the ischium itself, other than knowing that it's part of the acetabulum, note that there is a spine of the ischium and a ischial tuberosity. So let's look at the back side here. The ischial tuberosity, just have somebody sit on your legs who has kind of a bony butt. You'll feel their ischial tuberosity. Now the spine of the ischium here there's a sacrospinous ligament there that's of interest. But those spines on a woman can kind of determine the inside diameter for the passage of the baby. So you can palpate, not easily, you'll have to kind of get in there, but you can palpate the spines of the ischium and judge the size of the opening there. Pelvic Foramen. I really should review this section. This is the Obturator Foramen, right here, the whole area. This is the obturator membrane, and so we'll just hide that. That's the Obturator Foramen. And seriously, you'll have students that think babies come out of the Obturator Foramen. No. They go through right there. You have a pubic symphysis, fibrocartilaginous pad between the two pubis bones, and of course this can be palpated as well, just superior to the genitals. The pubis itself basically has two branches, so there's an inferior ramus and a superior ramus. And the ilium, finally. The ilium has a crest, a large crest, iliac crest, which, hands on your hips, you're feeling the iliac crest. And the anterior point is the anterior superior iliac spine. And it sounds pretty fancy, but it's just think about the position. Anterior superior iliac spine, you can palpate that. And on the back side, you're going to have a posterior superior iliac spine, which you can also palpate. And because you can palpate the iliac crest and draw an imaginary line, look at this. 1, 2, 3, 4. Draw an imaginary line. You can find L4 on a person and say, okay, I'm good to do my, I can do my puncture, lumbar puncture, either L3, L4 or L2, L3. L3, L4 is a good spot. Anyhow, so anterior superior iliac spine, posterior superior iliac spine. And if you're going to have a superior, you might as well have an inferior. So there is an anterior inferior iliac spine and a posterior inferior iliac spine right there. These are not easily palpated, right? They're deeper structures. And by the way, remember, this is one of the bones where hemopoiesis or hematopoiesis occurs. Both those terms are correct for making blood cells. If you need to sample some bone marrow or get a bone marrow donation from somebody, this is a pleasant, no, it's not pleasant, but it's a nicer place to get bone marrow than from the sternum, because you can imagine this great big needle going into your sternum and you're thinking, oh, my heart's right behind there. Whereas here you're just laying face down and, like, you know, this is where I would rather have the bone marrow sample taken from, because you can find these posterior, superior iliac spines and go in there. Oh, this has a name. And I don't remember right now. So, ta-da, that's the ilium. And you can see it's, you know, bowl shaped to help hold the pelvic, help form that pelvic bowl. And our whole pelvic system looks quite a bit different than other mammals because of our upright posture. And so when they talk about early humans, and, you know, that, oh, look, Australopithecine walked upright, is based on the structure of their pelvis. Okay, back to the rest of the story here. Let's do the femur. The femur, not surprisingly, we're going to have ligaments here, and the femur has a very distinct head, and nice and round, and a neck. And if I could, oops, if I could, yeah, I might be able to. Let me just disappear this for a moment here. Hide these things. I just want to show you a landmark on the head of the femur. Okay, so, and the landmark doesn't really show up. There's a little hole in the head of the femur, and there's a ligament that attaches there, glenofemoral, or no, acetabular femoral ligament. Anyway, there's a ligament that helps hold it to the acetabulum, but there's a little hole there which gives blood supply to the head and neck of the femur. And as you get old and get arthritis in your hips, that blood supply gets cut off, and so this portion of the bone may die, and then it becomes weak. And so then you're walking and crack, you break the neck of your femur, and they say you broke your hip and that you need a hip replacement. Well, this is what you broke. You broke the neck of the femur, and you may have heard, oh, it breaks before you fall down. That can happen. You can just break and then you fall down, or you can fall down and break it in the process of falling down. Either way, being old and getting osteoporosis is already going to make it more likely, but getting arthritis in there and losing the blood supply is what weakens it, because that should be very strong. But when you do break it, they're going to go in and cut away muscles and everything to get to this point. They'll just saw it off. They'll open up the medullary cavity. They'll put in a new hip joint here, a new ball joint, and embed it down in. Nowadays it doesn't go down too far, and they pack it with your own bone cells. They used to glue it in, but now they pack in your own cells to help it just grow into place. They're also going to ream out the acetabulum and put a plastic cup there instead. So you'll have a plastic cup and then a metal head and neck, and it goes down into the femur a little bit. Okay, there's a greater trochanter and a lesser trochanter. They could have just said tubercles, but hey, let's be fancy and come up with a new word. And this is the only place that I know of that these words are used: greater trochanter, lesser trochanter. And this greater trochanter is the widest portion of your hips. So hands on your hips, you're actually on your hips, but the widest portion of your hip, you can feel the greater trochanter, and that's femur, not part of your pelvis, right? Okay, So head, neck, greater trochanter, lesser trochanter, and it's referring to running because we have running muscles, shaft or diaphysis, distal end. Oh, what a brilliant idea. We got the patella here, and let's just call it the medial and lateral condyles. Thank you, they did that. And then there's going to be a medial and lateral condyle on the tibia as well. So if we hide the femur and look at the superior surface of the tibia, maybe I can get to the superior surface. Maybe I can do this. There, nice. So we can see the medial and lateral condyle, and there's cartilage here that's going to help hold it in place. And they're called meniscus, medial meniscus, lateral meniscus, forms kind of this thing. And then we also have our posterior cruciate and anterior cruciate ligaments that go between the tibia and the femur. And so when you hear somebody tore their ACL, that's their anterior cruciate ligament. And this is the posterior, sorry, that I highlighted. Here's the anterior. They're called cruciate ligaments because they cross. See that? They cross. So the anterior cruciate ligament starts anteriorly on the tibia and it goes back posteriorly onto the femur. The posterior cruciate ligament starts posterior on the tibia and it goes towards the anterior portion of the femur. So that's the posterior cruciate ligament. That's less likely to get damaged. People do tear their meniscus, and that's slow healing because there's not good blood supply. There's no blood supply to the cartilage. They'll sometimes tear their medial collateral ligament as well, and sometimes just for kicks they'll do the lateral collateral ligament as well. So sometimes you'll get all three, you know, the ACL and the lateral and medial collateral ligaments. So I don't know, knees are not super stable. From the patella we go to the tibial tuberosity, which is the bump underneath that ligament there, where really this is where the insertion point is for the quadriceps muscles. So this is, you know, what's going to allow your knee to kick there. Here's the fibula, just lateral to the tibia, and it's not bearing any weight, right? And it took me a while to figure out what the word fibula meant. It's a clasp, you know, like if you were a clasp for a brooch or something. So it's just like a little pin, you know, that you would pin something on with, or clasp. So there's no weight bearing on the fibula. It's not, it does help stabilize the ankle joint, and some muscle attachment and stuff, but it's a weak bone because there's not a lot of weight on it. All right, and remember how we had styloid processes of the radius and ulna? Well, here we have little hammers. So there's a medial malleolus or malleolus, little hammer, and a lateral malleolus. So the fibula is very simple, it just has a head and a lateral malleolus or malleolus. And it's kind of tough. If you just have a fibula, it's a little bit tough to figure out which is superior, which is inferior. You know, is this a left or a right? It can be a little tough. Okay, the tibia, we don't have a head, we just have the condyles, and we do have epicondyles. The sides of your knee are epicondyles, medial lateral epicondyles. The shaft, and there's a crest that you've felt many times, you know, your shin, the tibial crest there, and you've got muscles associated with that. We talked about the medial lateral malleolus. Oh, I didn't get the groove up on the arm where the two bones articulate with each other. You can see that there's a fibular notch here on the tibia. If we were to go back up here really quickly, navigation problems. Not quite done, almost done. Well, no wonder we didn't get it. The proximal end of the ulna, holy smokes, I'm not going to be able to navigate there. Proximal end of the ulna, where the head of the radius articulates with the ulna. Let me fade that. Let me show this. There's a groove, a spot. Never mind. Back to the ankle. Okay. You know what? We're basically done here. We talked about the talus. We talked about the bones of the ankle in the earlier video. I'm just trying to get a lateral view here so we can just say, hey, look, we had metacarpals, we had carpals, and we have tarsals. And we're not going to go through the tarsals one by one because I did in the other video. So then we have metatarsals, and then we have phalanges. And same basic idea with the phalanges of the foot as with the phalanges of the hand. We have distal interphalangeal joints, we have proximal interphalangeal joints, and we have metatarsophalangeal joints instead of metacarpal phalangeal joints. And instead of a pollex, we have a hallux, is the word for the big toe. All right, we're going to call that good. I'm done for today.